Dr. Raj Makkar is ready with the case. And as you take over, I request other panelists, Dr. Amit Chaurasiya, Dr. Manokar, Dr. Manik Chopra, Dr. Sharad Reddy to join, please. Over to you, Dr. Pinto and Dr. Saru.
Thank you. Thank you for inviting me, Dr. Kumar. Hopefully, Dr. Grube can stay on as one of the most experienced TAVR operators on the planet. So, you contribute a lot more than I will,
No, my friend, not right.
Okay. Nowadays, this new look of beard, we call it as COVID looks. After COVID, we wear masks and we don't go for anything. You're looking good, great, but go ahead, sir. Thank you.
Okay, terrific. I want to thank Dr. Kumar and the organizers of the meeting for inviting us to show some live cases. I want to thank our staff who came in really early this morning. So to my right is Dr. Mamu Nakamura, my associate, Yusuf, and then of course we have Arvind, and of course I have my surgeon brother, Dr. Wencheng here. I also want to thank our nurses and techs here. So there's Jen and Ruchi and Marcella and Premal. They're all here. Dr. Scaff is going to help us with the TE. And we have, who's our anesthesiologist?
Dr. Lai.
Okay, Dr. Lai is actually giving us anesthesia support. So let's go ahead and get started. We had to change our case last minute, and if you get time later, we will show you the case that we were supposed to show you live, but we had to do that case urgently. But we did save some slides. Now, so let's go ahead with the slide presentation, please.
Okay, great. This is a 80-year-old man presenting with progressive dyspnea exertion with severe aortic stenosis. The mean gradient was 41. The valve area was 0.6 and was referred for TAVR. His medical history otherwise is notable for hypertension, hyperlipidemia. A pre-TAVR CT analysis showed the annular area was 493, perimeter of 80.4, dimensions of 22.5 by 28.1 millimeters. The LVOT was 457. The sinus of Valsalva right was 30, left 38, non-cusp 34. STJs were a mean of 31. The ascending aorta was 36.4. Next slide, please. The right coronary height was 17 and the left was 12.6. So there was relatively low risk for coronary occlusion. Next slide, please. There is heavy valve calcification and as well as moderate LVOT calcification, as you can see here. Next slide. It's a type 1 aortic arch. Next slide. The iliofemoral anatomy is suitable for a transfemoral TAVR. The approach is going to be right femoral artery access.
All right.
So case summary, this is severe symptomatic aortic stenosis of trileaflet aortic valve. The procedural strategy here is going to be transfemoral TAVR with a 26 millimeter SAPIEN 3 Ultra valve. Pre-dilation first with 18 millimeter balloon. Patients enrolled in a PROTECT TAVR study for cerebral protection.
Okay, terrific. So Saba, can you give us a quick tour of the echo, please? Now, this is a case we would actually, do a lot of times with conscious sedation, but in this case, we happen to be doing this with TE guidance. So Saba?
So here we go. So here you see in a long axis view of the aortic valve, you can notice the leaflets are calcified. You're getting a lot of shadowing. They're restricted. The valve looks stenotic. We're adding some color here to see there's also some moderate aortic regurgitation. And I just showing it here. It's a little bit eccentric. And I took some measurements of the aortic valve. Here you could see it on, the 3D. You could see the short axis of it. It's really restricted. There's looks like severe aortic stenosis visually. And then we took some measurements of the gradients. And here you're seeing the analysis by 3D. We're able to do a 3D reconstruction and I'm getting an area of 490 millimeters square. And then looking at the gradients, this is the VTI of the valve, and this is the gradient. So you could see the mean gradient is 50 with a dimensional index of 0.22, which is consistent with severe aortic stenosis.
Okay, terrific. Thank you so much, Saba. So let me just show you some pictures that my colleague Mahmood took. And what we are showing you here is actually an injection. So what we do typically in our lab is we use a micropuncture technique. So what Mahmood did was actually use this 19 gauge needle, and there's a micro wire. And then in fact, this is a 1 French catheter. So if you're not happy, you can come out and you can actually restick or leave this in. And while you're injecting through this, inject at another point. So I think, so in our lab, we don't use the 18 gauge needle anymore. So whether it is sticking the artery, vein, pericardium, micropuncture is what we use. And I think that it makes a difference in making things safe. So,
No, Raj, it's Dwayne Pinto.
Hi, Dwayne.
I'm in Boston. We're collaborating now in Los Angeles and Boston by way of Hyderabad,
Yes.
But, if you go back to that one picture, one thing
Yes.
that I've done with this micropuncture technique is you see that stiff inner dilator. When I've had it like this against the blood vessel, sometimes
Yes.
when I inject, I have dissected the vessel. So
Yes,
I think that's one important consideration. It's right up against it there.
Sure. Sure. So Dwayne, there are different types of micropuncture, and you are right. There is one with the inner core that is very stiff.
Yeah.
This is actually
Yeah.
very soft. So I don't know if you can see this or not. I'm
Yeah.
bending it. All right. So this is, those of us who train fellows find these little things very meaningful because these things actually enhance the safety of the procedure. So the coronaries are actually pretty okay here, and we don't do coronary angiograms now before TAVR. Most of the times we do it now at the time of the TAVR procedure. So the left main is pretty short here. It's almost like a separate ostium, but you can see some calcium in the aortic valve as well, actually, which was nicely shown in one of the other views. This is the right coronary artery. And now this is where you can actually appreciate the calcium in the aortic valve. Now, I somehow thought that we missed showing you the CT image of where we actually saw a lot of LVOT calcium on CT. Now, you can see that a little bit here. I don't know if you can appreciate that on your screen or not. You can see some LVOT calcium right below the left cusp. So this is not, this is not a very complex case, but we thought we would just still try to make some teaching points. But it is a very tight aortic stenosis. Now, this morning, we randomized this patient. We actually had a neurologist assess this patient at 5 o'clock in the morning. And it so happened that he randomized to the Sentinel device. So, for those of the people in the audience who are not familiar with this particular device, this is called the Sentinel device. And we are currently enrolling patients in the protected TAVR study. It's a large study, 3,000 patients, to test the concept whether using this device is going to actually reduce stroke. So this is the proximal filter, which is stationed in the brachiocephalic, and this is the distal filter, which will actually go into the carotid artery. So, Mamu, if you can go ahead and reassemble this, sure. Yeah, so that we can, yeah. Okay, so let's just go ahead and reassemble, and we will start with the, with the deployment of this device. Okay. So Mamu is just making sure that these.
Let's put this one in there.
Okay. Now, while we do that and while we advance the Sentinel device, do you have any questions or comments? We can.
Hey, Raj. Good morning. It's Saurabh from Portland, Oregon.
Good morning. Good morning, Saurabh.
Talk to us a little bit of your strategy around where you might use TEE up front rather than just, for example, by happenstance, as in this case.
So I would say that we are still a center that uses quite a bit of TE because we've adapted TE to our use. Our median length of stay is 1 day. Most of these patients go home the next day. In fact, a lot of patients go home the same day. We don't find that using anesthesia and TE significantly delays things in our setting. And at times with the volume that we do when you're doing 700 cases and you're trying to say this one goes for TE, this one doesn't go for TE, things get a little complex. So there was a time when we were doing a lot of just, conscious sedation. But I have to say that with so many TAVR centers now and routine TAVRs being done at most of the peripheral hospitals, we tend to get now a lot more complex cases. But I think that for bicuspids, for example, I would always favor the use of, of TE, because we want to, make sure that we are not missing leaks. A lot of these patients are young, heavily calcified valves, LVOT, where the valve is actually, but there's a lot of calcium. So I think some of those cases are very low EF. There are times when you end up doing really patients who are low EF and you want to have a lot of control. So I think that's another place I would tend to do it. So I think that both of these strategies are fine. It all depends upon what you can adapt to your place. Okay, so you saw that we deployed the first filter, we deployed the second filter, and I'm now going to advance this. Okay, so we are up in the carotid, and now we're going to deploy all right. So I think it's very clear that, and I'm going to pull it back gently so that it's flush, okay? So go ahead and let's take a picture and show this.
I think that was a very expert deployment of the Sentinel. I mean, it shows, with obvious skill and practice. I have some trouble sometimes with different shaped arches and such.
Dwayne, in your center, are you using it routinely?
We don't routinely use it.
We were using it routinely, and we did so for about 1,700 cases. I think the data from the TVT registry was not very strong. And so we thought that the right thing to do is to do a randomized clinical trial. So we are actually now enrolling patients in the randomized clinical trial. And, there are 3,000 patients that will be enrolled in this study. And I think we are almost up to like 1,800 patients. So I think there's going to be an interim analysis around 2,000 patients, which will then dictate whether we do the additional, 1,000 patients and, so on and so forth. So I think that is the right thing to do, I feel. Now, there are some young patients and heavily calcified valves. Have I broken, heavy changer rules in those patients? The answer is yes. All right, so.
I think Raj is right. It's an important advance to get this data from randomized trials because.
Yeah, so as you saw that we used an MPLATS 1 and we've actually crossed the valve. Okay, so, for those of, for the new operators in India, I just want to say that, it's a good idea to use MPLATS and a straight wire. Most of the times, actually, it'll work. And to cross the valve like you're crossing a lesion. So, just go find that gap fluoroscopically and advance the wire rather than, a lot of times just poking it 100 times, and just seeing randomly. So I think if you find the gap and if it doesn't go, then sort of change the position of the MPLATS a little clockwise, a little anti-clockwise, etc. And most of the times you're able to do that. So, these are generally the steps that are actually in our lab done by our fellows, crossing of the valve, even advancing the catheter system.
Okay, so taking aortic route sometimes will help in seeing the pinpoint hole where it is and
yes, in fact it does. I think it's very. We showed you a picture at baseline where we took a picture, but you're right. It can actually help. It does help. But it's putting your pigtail catheter in the cusp, non-coronary cusp, it all of a sudden orients you to that space, and giving an injection also helps. Now, in this case, because the valve is tight, we will go ahead and we will pre-dilate. The goal is not to be very aggressive in pre-dilatation, but just so that you make enough room and you're not struggling while crossing the valve. So I would say that 80% of the times we actually don't pre-dilate. Okay, so in this case, also, when you're doing a live case, you don't want to struggle, but most of the times I would say that we don't pre-dilate. In this case, the calcium is relatively heavy, and the gradient, as you saw by echo, was quite robust. The mean gradient was what, 50 or something, right? So, okay, so let's go ahead and do some rapid pacing, please. Pacer on. Okay, let's go up. Down, please.
Open.
Off, please. All right. Okay, so let's just take this out. Now, this is just a 20 millimeter balloon, and I wanted to ask you, Saurabh, and Dwayne, what do you think? What do you guys pre-dilate, or what is your practice? Dwayne,
Saurabh,
yes.
please.
We generally have, but the newer platforms moved away. I remember the times when this was the old Sapien and you had to pre-dilate.
Yes.
And that
That's
was
correct.
mostly to facilitate crossing. With heavy calcification, I still am biased towards pre-dilating. I think it leads to a more symmetric expansion. So we're about maybe 50% pre-dilatation in the Sapien arm. And then in the self-expanding platform, it's perhaps a little less. And we do the same. We use an undersized balloon and do a rapid up and down. Dwayne, what's your practice?
Yeah, we're infrequently pre-dilating, as Saurabh said, but the lesion sets or the patient sets that we do pre-dilate in is bicuspid valves, especially with heavily calcified raphe. I find that when there's under expansion, particularly with the self-expanding valve, I'm worried about a pop out. And I don't want to aggressively deploy in a bicuspid valve with the Sapien. And so that's one set. You cross so easily with the AL, but sometimes it's very difficult to advance the catheter in, or very high gradients. We'll maybe pre-dilate those patients, but we're still in a vast majority, maybe 10-15% of pre-dilation. Raj, I don't know where you're at, but
yeah,
and one minor.
I think we are where you are. I think I think about 20% of the times max. I would say, yeah, I think that's where we are in terms.
We have a minor difference in how we cross the valve. Is we go with the AL, and then we exchange for a pigtail and measure gradients, because sometimes it's difficult for me to tell whether I'm under a cord or something, and just to make sure that it's free, I'll free it up just under the valve with the pigtail, take a pause, measure gradients, make sure everybody in the room's on the same page. We're usually still prepping the valve at that point.
Yes. Yeah, I think that's a good point. I think if we and we've thought about whether we should add that step, so I think it's a good practice. And I think you make a very good point, especially, as you start doing these cases early on, to be extra careful, to make sure that you're not entangled in the cords. So those are all very important points. I would completely agree with you. And we've talked about using the pre-shaped wires, but we've sort of, I think that with the Sapien, I feel that having a very rigid wire actually sort of at times goes against you, so unlike the self-expanding valve,
Raj, what do you like for cusp overlap self-expanding valves? We've been advised, we still use Confida, but we've been advised to move to Lunderquist for cusp overlap.
I have to say that I had such great reservations about using Lunderquist in the LV, because I thought we were going back to the previous decade of TAVR, in the early days. But I am pleasantly surprised, and the reliability with where it lands, with self-expanding is terrific with Evolut. So and using rapid pacing. So we've actually changed whenever we do self-expanding valves. So it's like almost relearning how to use the self-expanding valve. And actually, I have to say the results are much better. I have to completely agree with, the champions such as Hemal, who actually really pushed this. Okay, so this is where our valve is positioned. What do you guys think? Okay, so all right, Ben, what do you think?
I like it.
You like it?
Nowadays,
Okay.
nowadays you
Can you
moved
bring your
from
probe back a little
two-third,
bit, please,
one-third to
Sabah?
90%, 90%,
You know,
10%.
Yes, I think that's where we would like to land it. Let's see, how it ends up. Yeah. Okay. Pacer on, please. Inject, please. Okay, go.
We're not that.
Okay. Stop, please. Okay, we're not capturing. See, this is very important to have a colleague who's really watching that end. Okay, so did we not capture? All right, so let's do that. All right, can you? Okay, when you will go up when you see that we are fully captured. Okay, all right. Are we ready again? Pacer on. Are you testing right now?
Other
Okay,
way
it's
to
because
see is, I
it's
think
not-
pressure should become zero totally when you're rapid
Yes.
pacing, so that it
Okay,
helps.
so what is your rate?
108.
180? Okay, so we didn't, for whatever reason, I guess we were not capturing. So let's just go ahead and try again. Ready at 180? Okay, all right. So it's still not capturing every beat. Yeah. So that's why, let's see if it,
Now it's okay.
Sometimes, yeah, there you go.
okay, go up. Down,
No.
off, please. All right. Can you look at our valve, please? So when, tell us, did you leave any volume behind? Or did you give us, this was nominal?
This is nominal.
All right.
So far.
So we see that there is a little bit of PV leak there. So the question is, there was a rod of LVOT calcium. All right. So I think this was one of the things that we had seen. So the question is, this is what would you call this, Sabah?
Taking a look at this leak, so we're seeing this leak. It's very close to that, the commissure between the non and the left. I think that's where it's coming from.
Uh-huh.
And then there's so it's leaking a lot, mild right
Okay.
now.
Okay.
So, but you gave all the volume, right?
Yeah. So I think maybe we can.
Extra I didn't give.
So we may just go ahead and give a little bit more, maybe an extra CC, and see if we can make this better, because there seems to be a little bit of a gap there, right? So I think we have to be careful here, because he's 80 years old, and mild AR is not going to affect his prognosis. He had baseline aortic regurgitation to begin. So we don't want to cause aortic root injury. And of course, when you're doing TE, you will pick up these little jets. So let's go
Raj,
ahead and do one more.
can you describe your hands in the first position when you're deploying? I find that's the
Yes.
most difficult thing. Do you use the knob? Do you push with your left hand when you need to make small adjustments?
Yes. So basically, no, I'm just using my left hand, and if I need to, I will just push it with the right hand. I'm not using this knob when the rapid pacing starts. We can use this knob to position, before the rapid pacing.
Yeah, I find
Okay,
that's
so-
so difficult
yeah.
to do anything
Yeah.
with the knob. So it's always forward and back
Yes.
with the left hand.
That's correct. That I agree with you.
Yeah, we're not
Okay, so
using
we
the
will-
knob at all. I don't even use it for original positioning. So Raj, were you looking at the inflation gauge with the original deployment? Like, do you give some credence to the theory that if you've gone past 6 atmospheres or so in these LVOT calcium patients?
Yes, when we'll always look at it, and he will say, and a lot of times actually they'll stop and not go beyond 7, and we will rather go and do another inflation. So I think that will happen. Okay, so let's go ahead and do
And
another one.
Raj, do you believe
Yes.
in this visible line business, or do you position it on the marker? What's your
I just look at the
most
valve.
experience?
I look
Yeah.
at the valve itself. I don't look at the other things.
Yeah, lucent line and stuff. Yeah.
Yes. Okay, so let's hope that this will not be counterproductive. Another balloon dilatation. All right, so balloon pacer on, please. Okay. No, still not. I think okay. Yeah. Yeah, our pacer. Yeah, let's go up.
Going up.
All right.
Going up.
Down. Off, please. So one more CC, and you know, a lot of times you can see that the valve is better expanded. Okay, and we see this often, you know, even if you keep the volume same and you go up, in this case, of course, we gave an extra CC. Now, can you bring, you know, let's show you fluoroscopically, it is more stretched, the valve. Okay, so let's just take this out. Okay. Oh, so our wire came out, which is okay. Can you show us?
God is telling
The
us to
valve
stop
definitely looks better
dilating further.
expanded.
Right, so the valve is better
And
expanded.
then the gap has decreased. And as you could see, the PVL decreased and looks more like trivial now.
Yeah, so it's, I think, trivial. Can I have a J wire, please? Because I think it'll be nice to show the gradient. So it is our practice to measure gradients routinely. You know, we are a teaching hospital, so we're trying to do that. Okay, so we've crossed it. We had lost our position, but we've crossed back again with the pigtail. So that's also
I
something
think,
to
Raj,
remember.
it's a super important point you make. It took the person 80 years to get onto your table. Maybe you can spend 8 minutes doing it right by measuring the gradient.
Yeah. Okay, so here is also, I think, you know, these hemodynamic tracings make for good case. You know, when you send these tracings to your referring doctors, you know, they like seeing those, and it's helpful. So while Mamu is going to flush the lines and do this, I'm going to go ahead and remove the Sentinel device. So the first thing, we are pulling the carotid filter in. I'm going to pull back the wire. Now, next thing I'll do is I'll relax it a little bit and push it out of the carotid. All right. I will unflex it now. Mamu's going to advance the wire. I'm bringing this here. Now I'm going to go ahead and capture the brachiocephalic filter. So the key is to bring the sheath on top of the filter rather than bring the filter back to the sleeve. All right. So this is out. So the filter is out. So look at the gradients there. Are you able to see the hemodynamic gradients?
We are. That looks perfect.
Right. Okay. So those are the findings. Now, Mamu is going to go ahead and close the groin as I move to the other room with my other colleagues. Okay. So while you're showing that, I'll head over to the other room.
Sounds good.
Okay. Is that reasonable?
Raj,
thank
can
you,
you
sir.
show if you had anything in the filter for those who don't use that? Like, do you routinely look if you had any debris in it?
To be honest, we don't routinely look, but in fact, last time we were doing a live case, they wanted to look at it and we looked at it. And actually it so happens that there was a piece of calcified material in the you know, just about a week ago, when we did another transmission. So we don't routinely, we used to look for it routinely. And I think then what happens is you get busy and you want to move on to the next case. So that's the true answer. You know, we don't do it.
I mean, you're not going to do
All right.
anything different if you see something in there or not.
Yes. Yes. Okay. Perfect.
Great.
What is the routine? You're closing your strategy? You close with per close or you use Manta
We
device?
usually use a 2 per cross in here in the pre-deployment, and it depends on how things go. This patient in the vessel caliber is pretty large, so even with the 2 per cross with therapeutic heparin, it's probably going to see the leak, like just almost like a, you know, aortic leak, like just a pulsatile flow. My personal way to do these things, I don't chasing the perfectionism for these 2 per cross. If you are perfectly able to hemostasis fine, like a fantastic, we'll take it. However, my goal is like just make this 14 French or even bigger hole is like a 6 French or 8 French equivalent. And unless patients have any contraindication, like then we do the protamine and then reverse and happening the manual hold the groin. And the most likely it's going to take care of all those hemostasis for the big ball porous catheter. Now, if you have the more a significant, really bad pulsatile flow, then next strategy depends on how things go. I usually like to look at all those iliac artery, make sure there's no significant stenosis, just only extravasation. Then if there's no stenosis, then we will just do the either 6 French, 8 French, 11 French sheets back in there, and it's it's a terminated complete bleeding, stop it. And depend on which side of the sheaths we need, we may either pick up doing the angio or just do the one more percross, or decide to go for the protamine and manual hold groin. So we usually routinely do these things with the rim catheter up and over. We're just gonna take this out and leave the 035 wire in there. It's a little bit hard.
I think, Saurabh, what we have seen differently here is two schools of thought. One, they're telling they don't use echo at all. Ganesh said everything done in the cath lab based on the angio and cine. But here you see the other view where echoes, pictures actually, it all depends upon how comfortable is your echocardiographer and what are your systems. They showed fantastic pictures where you can confidently tell there is no AR and valve has expanded quite well. So it's also important to have echo. The problem with echo is it's not operator dependent, and that's how I think each
absolutely
team,
yes.
And I think part of part of this is the institutional comfort with what your flow is. And Raj and I have talked about this, but he's mentioned even today that in their labs, general anesthetic and TEE does not really lead to any slower turnaround times, right? Because a lot of the TEE transthoracic data, at least, is towards whether you could A, do them conscious sedation, and then B, could you do that with a faster turnaround time in terms of efficiency?
Right.
In our lab, TEE is an exception.
I think we are very comfortable doing this system. Anesthesiologist is very comfortable to secure the airway, and the patient is completely calm. And we have a very good control for the system. And also, fellow can spend the extra time to getting access and doing the crossing the valve. So we have the ample opportunity for them to give them a hands-on. So,
I mean, I think, this is a false kind of dichotomy that's created is, yeah, you can save maybe 10, 15, 20 minutes in the room, but in the context of the patient's entire stay, what do you give up for that? And in certain patients, a TE is valuable. In certain patients, maybe it's less valuable. But, I wouldn't focus on the TE. Everybody's, focused on the minimalist and all that sort of stuff. I think you just make decisions that you think are right for the patient. And
I think so.
You can waste 20 minutes on access. You can waste 30 minutes on, these sort of things.
And I think it's also the anesthesiologist's comfortability. Like if the patient have the body habitat difficult, the airway, they rather want to get the airway first. Now we are.
But the whole idea that transthoracic is associated with a mortality benefit, in other words, TE is killing people. So
now I think the other room is also ready. So we are down here, and it looks to me like a hemostasis is successful. We'll just make sure one contrast injection. Can you just perform please here?
Do you reverse with protamine before you remove the sheath, or put this, or you don't?
I usually make sure that there's no occlusion in the artery. But I think this one, the problem we can give a protamine. Test that.
So it's not a question of only time, but we feel some of the contraindicated patients for general anesthesia we miss out. That is because one of the advantages we claim is we don't need general anesthesia for this. So that is
right.
The other thing, what about the disadvantage because?
Okay, we are ready. Okay, so can we get started with the next case?
Dear friends, greetings from Fax Foundation, TCT India South Asia 2021. This video brings you the live case learnings of a very interesting TAVR case done by Dr. Raj Makkar from Cedar Sinai Institute. This octogenarian patient had severe aortic stenosis, which was tackled by balloon expandable Edwards Sapien system. Initially, to start with, he highlighted the way the puncture should be done, especially when you have fellows to getting trained. He said doing puncture with the micropuncture technique with one French needle and the catheter has eliminated the problems of groin and the femoral artery complications he felt. And we also demonstrated the soft one French micropuncture set, which tends to avoid complications. And he recommends this to be practiced. And later on, obviously, once you do a puncture, then you select the appropriate site and then probably go on to the right puncture in the right spot over the femoral head. And this will help. And suppose if you prick the artery in a wrong place, even if you remove, he felt it shouldn't be a problem because of its one French nature. So this way, if it is practiced, probably he felt that you could avoid femoral artery complications and the puncture can be done in the right site. The other interesting aspect which I liked in the case demonstration is he said the aortic valve has to be crossed like we cross the coronary lesion. You see the calcium, you see the pinpoint hole of the aortic stenosis and aortic valve opening, and try to take the wire. Probably he felt that Amplat's catheter and 6 French catheter with a straight flexible tip wire could be used to cross the aortic stenosis, and he said it has to be crossed in this system, and rather than blindly poking here and there, which will create trouble and waste a lot of time. And if at all you find more challenge in seeing the pinhole meatus of aortic stenosis, probably taking aortic root angio would also help to localize and see the valve opening and helps in crossing the aortic valve. So this, he called it as crossing the aortic valve like in coronary arteries, like what we are comfortable with coronary interventions. And the other important aspect, occasionally when you find some challenges in crossing the valve, then he said putting the pigtail in the non-coronary cusp also gives us the orientation and helps us in crossing the valve. And then probably same Amplat's catheter usage with clockwise turning a little and then trying to cross the valve will help us to cross the aortic valve in difficult scenarios. The other important thing which was different with Raj Makkar Center was effective utility of transesophageal echo guidance throughout the procedure. This, he felt, is very important, especially in patients of severe airway dysfunction and patients with difficult calcified anatomies, unusual anatomies. It will help us in proper positioning of the valve. And it was also shown effectively that the valve positioning and the minimal paravalvular leak which was left after the procedure, which is again sealed off with the 1 millimeter ml dilatation more of the valve. So all these were effectively demonstrated by the transesophageal echo guidance. In his institute, he felt anesthesia as well as TEE got so organized, this will not hinge or delay the patient's discharge, because most of the patients again still get discharged the next day morning itself. So he felt this system, if it is implemented properly, could be better, especially in setups like his where you get a lot of high risk complicated cases with state-of-the-art TAVRs being done elsewhere. So he also discussed regarding the PROTECT TAVR trial. PROTECT TAVR trial is basically when the NCDR data of aortic valve TAVI registries were seen, the benefits of sentinel protection devices were not seen very clearly. So they have planned this randomized trial of cerebral protection with sentinel device, where about 3,000 patients are about to be recruited. In one group of patients in which dealing with the placement of sentinel device, other group not placing sentinel device, and about 1,700 patients are recruited. And he said after 2,000 patients interim analysis will be done and will be presented in TCT. probably to show whether placement of sentinel device helps or not. But he felt it could help many of the times, especially with chunks of calcium in younger people. Probably he could use this. And the placement of sentinel system, how it is placed in the brachiocephalic artery on one side and the carotid artery on the other side, was effectively demonstrated. And after the procedure was over, the removal of the filter sentinel system, and how we should take care not to pull the filter into it, but take the sheath onto the sentinel filter was highlighted. This will help in preventing the squeezing of the material and getting the problems of stroke. And this was effectively, elegantly done in 2 to 3 minutes deployment, and then probably taking it out, shown effectively by Dr. Raj Makkar. Then after the deployment of it was done, the minimal paravalvular leak, how it was there, was seen very well on echo guidance, and then by increasing it 1 millimeter, 1 ml dilatation further with the inflation device, it could be effectively sealed off. It was very well shown, and he also stressed upon the fact that final aortic valve crossing and taking the LV aorta pressures and doing aortic root angio to demonstrate there is no AR. He also advised all of us that showing that pre and post procedure tracings and sending them to our referral doctors could also make them happy. And finally, Mamu of his team showed the percutaneous closure of the puncture site, and he felt that probably if a puncture site is too long, he could be also sometimes be comfortable leaving a 6 or 7 French hole where it could be also closed with application of pressure and then manual compression and the reversal of protamine. But in this patient, it was effectively closed percutaneously. I think these were the learning points. One of the very important point I thought is effective usage of transesophageal guidance throughout the procedure and assessment of PVL through it, and then probably the sentinel system placement, and then how to remove it, how to avoid complications, was effectively demonstrated by Dr. Raj Makkar from Cedar Sinai. Thank you. This is Dr. A. Srinivas Kumar. Hope you all liked and enjoyed these live case learnings from Dr. Raj Makkar from Cedar Sinai. Thank you.